Okay, so the video we have been waiting for. I know that for the two classes that I'm making this video for are for both mental health classes at San Jose State as well as Mission College. And we went over similar information. So this is a really nice tool that I can use. I can make one video. Now, these medications specifically are for addiction, withdrawal, certain things like that. Of course, we're not going to be able to cover every single one, but I want to give some bulk due to you taking your boards and just having a little bit more understanding. And I know that we have finished this part, San Jose State, I believe, about 2 weeks ago, Mission College last week. So it will definitely, I think, help again bring more stuff together. I'm going to try to keep it simple, short, and sweet, if you will. My goal is no more than 40 minutes. And that is not because I want to hurry. It's more because what is the most important thing to remember about the medication, if you will. So if you see it on an exam, or it just may, kind of ring a bell. And also, like I said, kind of being able to connect it to certain things. So the first thing that I want to mention is, and I do believe I mentioned this in class as well, that, well, I did actually, when I was on your quiz, that for anti-craving medication, so there's, of course, a difference between medication that's going to help with withdrawal, so that acute phase where you're coming off of a drug. So, for example, it could be either alcohol, benzodiazepine, a stimulant. I think I said alcohol, opiate. No matter what category, there can be, of course, a withdrawal. Some people don't have it as bad as others. And there's all sorts of things that can have a variety in a way of that. I mean, somebody could be drinking way more, but still have less withdrawal than someone else that's drinking much less. So I just kind of wanted to throw that out there. I think I mentioned that, but just, I mean, I've seen patients that drink one bottle of wine a night, and then they come into group and people are like, that's all you drink? I drink four, and it's like, they're still, considered under the DSM-5 as having an alcohol use disorder. And maybe the person that's drinking four doesn't have heart, like, as many symptoms as a person in a withdrawal from the person that's drinking one bottle. So keeping that in mind, especially when you're working in the ED, potentially rehab, mental health, whatever it may be, you're going to be dealing with this population. So I think it's really important to have that understanding, again, that empathy. And I truly believe that nobody, again, is wanting and born or in their adult life, teenage life, says, I want to be an addict. I actually don't prefer using that word. My apologies. Alcohol use disorder or methamphetamine use disorder or sex use, or I don't think that's the name, but sex addiction. That's not what I want for my future. Okay, so I have to, me, always give a disclosure. So I'm going to give you just some information about each of these. They are all fair game for your final. Again, I make a study guide, so we don't need to freak out, but please, you listen to this. You don't need to take copious notes. You will know the ones that I'm going to put on the final, because I'll make a study guide. However, some of these are really important, especially because I kid you not, you probably, I would say at least 1/4 of the class will have a question on something having to do with withdrawal and safety. Because remember, we're nurses, so we assess what is the best next action. What do we need to be looking for if somebody's on something, kind of like lithium, for example. If somebody's on lithium and all of a sudden they're vomiting, shaking, not doing well, I'm going to check the chart immediately. Oh, they're on lithium. We need to get a lithium level stat. So that, we see something, we do the assessment, then we do the proper testing. We understand it because we understand the information. So that's kind of what I'm trying to do here. So let's first start with actually withdrawal. So this was on your quiz, but so back one step, that alcohol and opiates are the only two substances that right now we have FDA approved medication as well as off-label medication that we use to help with withdrawal. That does not mean that somebody that's on a stimulant such as cocaine, amphetamines, or methamphetamines, that we cannot help treat their symptoms, right? So if someone's super anxious, of course we can still give them Ativan. I'm talking about what is usually more indicated and what's more seen. And so some of you that are in the field and they've seen things and whatnot, I will mention little things on the side. But again, I don't want to overwhelm, because again, we're not leaving as psychiatrists or mental health superstars, although that's of course what I would want. So I will give you the needed information rather than, of course, I could do this and this could be a 5-hour video, which I don't think would serve anyone well, as we all have a lot on our plate, I think, at the moment, to be able to keep all of that in our head. So let's start with alcohol, and let's start with talking about alcohol as far as the withdrawal. So I think most of us know that alcohol, as well as benzodiazepines, so you can, I mean, if I wanted to, I could do a slash there. I didn't, but I will talk about something having to do with that. So alcohol and benzodiazepines are the two substances that I would, and again, please keep in mind, I'm kind of doing a more of an overall. Of course, somebody could potentially die coming off opiates and all of this. I'm giving you the big picture because I want you, that's usually what they're going to test you on. It's not the nitty gritty. It's more of the big picture. Do you understand things? Can you assess things as a nurse and be safe? So somebody that is coming off of alcohol and benzodiazepines, again, as a classification, it is they're under antidepressants, but they are benzodiazepines, which are, just to name a few, Ativan, Xanax, Klonopin, Librium, Valium. Those are kind of like the most common ones that people know of. There's a few more, but those are, I would say, the most common. And some of those, I'm sure, at least two of those medications on that list, you're like, oh yeah, I know that med. So those two things, if somebody is taking them in amounts where it's long term, and I'm not going to give amount of time, it just know that most questions are going to say, oh, this person came in, it's been 12 hours, they're having extreme tremors from both, because remember, alcohol and benzos go to the same part of the brain. So basically, and again, please don't repeat this to a physician, but in the the black and white of it, a benzodiazepine, so if you take let's say a Xanax, and you're taking 6 milligrams of Xanax a day, that's like basically alcohol in a pill form. You may not feel as depending on the person, of course, you may not usually feel as like high or kind of like that slurry, kind of feeling. It can make some people more tired until you build that tolerance. But then once you build that tolerance, this is what we're talking about here is, if you all of a sudden, for example, are taking 6 milligrams of Xanax, which is quite a lot, if you're taking it per day for, I mean, if it's for like 2-3 days because you're in complete crisis, that's completely different, and you're in the hospital or whatever it may be. And again, I'm not against any of these medications. That's not any, I think that they have a good purpose and use in the correct way. Of course, we don't want our patients to become addicted or, have habit forming or what have you. We want them to be useful, however, not abused, because it's really hard to get off of these meds. It really is. It's very, very difficult because your central nervous system gets irritated. So if I were taking 6 milligrams of, let's say, Xanax, or 30 to 40 milligrams of Valium a day, let's say, and all of a sudden one day I didn't take it, I would feel that. I'm not going to feel, all of a sudden I'm going to kind of start feeling a rebound anxiety. I'm going to feel anxious. I'm not going to feel good. I'm going to get a little bit shaky. It looks very similar to alcohol withdrawal, sweaty. It's not good. And what is the potential for alcohol and benzos? You have the biggest thing of danger is potential of seizures. And what tells us is your body will tell you. So again, if you are used to drinking a certain amount of alcohol, and your body is very specific on homeostasis, right? So it's going to know what it needs. So if you're used to drinking 1 bottle of wine a night, actually, let's make it 2. Let's say 2 bottles of wine a night. And then the next night you only had a half a bottle. The next day, you're probably not going to feel amazing. And then especially if you didn't make up for it. So that's why if in all those assignments, you'll notice that people will say, or Ruth Pote mentions, one of them, sorry, one of them mentions how Volkow, actually both of them and Pote mention, I mean, the drug or whatever it is almost doesn't even become pleasurable anymore. It's just taking it just so that you don't go into withdrawal. at that point. It's just so that you feel your new homeostasis, which is normal. So what do we take away from that? From alcohol, what we're taking away is that alcohol and benzodiazepines both have the potential to cause seizure. They have pretty potential severe withdrawal symptoms, acute withdrawal symptoms. People are sometimes hospitalized for this, and we do IV medications. And usually, how we do it is, and again, I'm not going to test you on all of this, and I will put it on the study guide. But I keep saying that again, and honestly, I'm so sorry. I don't know where that's coming from, but it's hard when you're just talking literally to the computer screen and you're by yourself. So my apologies. Everybody can detox differently. Some do it at home. I don't recommend that. I don't recommend it to my patients. I don't care if and I say just one bottle of wine, but I mean, comparatively to usually what I see, it's a lot more, but that doesn't mean that person cannot have a seizure. Absolutely, they can have a seizure. Or somebody that's been drinking a pint or 4 pints of vodka a day or 1.75, milliliters a day for 25 years could get off with no problem and then not have a seizure. So again, everyone's different. Now, the takeaway from this is, what is something assessment wise for nurses to look for if somebody comes in and they and you may not get this right away, but hopefully you'll be able to get it from some assessment and some, physical assessment as well as verbal, or if they potentially had an overdose, seizures for alcohol and benzos. Now, how do we detox off alcohol? We give you benzos. And so some people look at me like I have 18 heads, like, why would you give them something that's going to the same receptor that you just explained to me, and you're giving them the same thing? You're just supplementing one for another. Of course I am, because I'm keeping them safe. So what I'm doing, and I explained this in class, I mean, if there was another way we could do it, then we would just taper you off of alcohol, but it's very difficult to do that when you're addicted to alcohol. That's like me saying, okay, you can take let's say you love chocolate. You could just take a little bite, right? And this is obviously not like the best example, but we basically figure out, we do our conversion, and you learn after a while what's going to cover someone. And if it doesn't, that's what the nurse is there for, right? The nurse, we're awesome. We can say, okay, I'm noticing that the 10 milligrams of Valium Q4 and the gabapentin is not quite covering this patient. They're still, on my scale of the CWA scale, which I posted, it's still showing that they're not doing too well. They're still having, really high pulse. They're sweaty, they're not feeling good, and they're complaining. And you may start to notice, depending on the person, day 3 to 7, cravings might start happening and whatnot. So, okay, we have the safety factor down. So for alcohol, we give either benzos in the normal top 3 that I see. Everybody is different, but the top 3 that I see normally in the hospital is Librium, and that can be pill form or IV. And you don't even need to know that. Let's just stick to the basics here. Not because you're not able to handle it, but because I want you to really internalize that. So Librium usually is given in the hospital. That's what I've seen usually. I believe they're a little tiny yellow capsule or white. I can't remember. It's been a while. Librium, Ativan, and Valium. Those are the 3 most commonly given. Ativan is shorter acting, as we know. A, remember, beginning of alphabet. V, longer. I prefer, unless the patient tells me this works better for me. Okay, that's fine. I don't care. I don't care what benzo you want. I'll give it to you. If you tell me it and I see it to be true, that's fine. As long as a doctor, because I'm not quite there yet to be able to make that decision, is okay with it, or MP or clinician, let's say clinician. So then there's a taper, and then that's when the cravings start. So keep that in mind, and we're going to put that on hold. And now we're going to go to benzos. So then we have benzos. And what we use for benzos is phenobarbital. So phenobarbital is a barbiturate. I consider a barbiturate an old school benzo. It's not used very much anymore. I see it more used in dogs for seizures than anything nowadays. It is the same schedule as Ativan and benzos. They're schedule 4, so they're both considered habit forming. They both, like I mentioned earlier, why would you give one thing for another? But it makes sense, I think, once you understand it. We're tapering you off in a slow way to keep you comfortable and to hopefully prevent seizure and really bad symptoms. Because I mean, at least for myself, I don't want to see you suffer. So for alcohol, we give benzos and or phenobarbital. Clinically, and the research shows that both of them prevent seizures just about the same, unless it's changed in the last like year and a half, because that's the last time I looked it up. I try to keep current. However, providers have their own prerogative to do what they want. And listening to, I asked the patient. Personally, I think Valium is the best thing. Valium and gabapentin together, whew, perfect. But some people say no, phenobarbital really works for me. I think phenobarbital, personally, for myself, because I've actually had to take it for something before, it did nothing for me. Nothing. Absolutely nothing. And okay, I'll just be honest. I took it because I wanted to see. I'm like, what is this all about? Like, I wanted to know, like, what does this feel like? So I took a very low dose, and a high enough dose that I would be able to feel relaxed if need be, because my friend was taking it, and I wanted to see, like, what does this feel like? And for me, it did nothing, just like other patients. It may feel like nothing, and it was safe. And my physician was aware. I told my psychiatrist, is this okay? Can I try this? I want to see what it feels like because I don't know. And she said yes. So just as a side note, I wasn't just like playing with drugs. So with alcohol, you can take benzos or phenobarbital. Those are the two most common that are prescribed to detox. For benzos, you take phenobarbital, and or you can technically taper down off of benzos. Most physicians may do both. So it depends. Again, I'm going to put all this on the study guide, what you need to know. I'm just trying to explain it. Now we're going to talk about some anti-craving medications. So Antabuse, I think, is probably the most simplistic to understand, and we've talked about this. Antabuse is a medication. It lasts in your body for 1 to 2 weeks. It is aversion therapy, meaning it doesn't do anything in the brain. It works specifically on the liver to block the metabolism of alcohol so that your liver is not able to metabolize the alcohol. Therefore, you are just basically building up alcohol. It makes you extremely sick, and it gives you that aversion therapy of like, oh no, I don't want to come near it. The good thing about it, it lasts in your system for 1 to 2 weeks. So you can't plan for tomorrow that I'm not going to take my pill and then I'm going to drink. It's still in your system and you're still going to get really, really sick. Therefore, you still have that memory. It's kind of like having food poisoning. Like if I think I told you guys, I had a caprese sandwich years ago, like 7 years ago. And I still remember that's how much your hippocampus and amygdala remember. And ew, got so sick. Love Whole Foods, but still got so sick. Oh my God, it was awful. And I couldn't eat a caprese sandwich for probably like 2-3 years. And after that, because it was stuck in my mind, that negative reinforcement. Addiction's a little bit different, of course, but it definitely does help some people. It's not for everybody, but it's for some people. I could get more into it, but just keep in mind there is alcohol out in the universe. In our community a lot with hand sanitizer, things like that. So people can have a minor reaction to perfume and stuff like hand sanitizer and things with alcohol in it. However, it's usually pretty minor. It's not pleasant, but cognitively intact individuals, you explain that to them. I always have them sign a form and then explain the danger. People can end up in the hospital. I've never had anybody or heard anything about somebody dying taking Antabuse. So that's the gist of Antabuse. Camprol and gabapentin work very similar. So we know that gabapentin is classified as an anti-seizure medication. We use it off-label for many things such as nerve pain, which is neuropathy, insomnia, sleep, agitation, all sorts of things. However, now we've noticed that 900 to about 1800 milligrams, and I would never test you on the milligrams. I don't think the NCLEX would either, have helped with people who are struggling with cravings for alcohol. Because again, we're talking about cravings at this point. And they noticed that because GABA is one of the receptors that alcohol works on. So GABA works on 5 receptors. The 2 that we're going to talk about today, because again, I want to stick to the basics, is GABA and your opioid receptor. And I'll get to your opioid receptor next when we get to naltrexone. So the reason that Camprol and GABA gabapentin are similar is that we think, and we don't always 100% sure know how things work. With Cambrel, we believe what happens is it helps to normalize your neurotransmitters in your brain at a faster rate to become, so we have homeostasis before we become addicted. Then we switch to a different homeostasis, of course, because that becomes your survival mechanism. I need it. I need this amount to feel good. That's your sole purpose. It's like, it can really, unless, I mean, I don't know who's gone through this or, family members, but if you've seen it, it's really scary. It's really sad. It's emotionally takes a huge toll. It's a very difficult disease to treat, but very rewarding as well. So Cambrel basically helps to kind of help even out your GABA receptors and your glutamate receptors. You do not need to remember those exact terms, but GABA and glutamate, they work kind of in balance of each other. A lot of neurotransmitters do that. So GABA is what we consider, you actually produce GABA in your brain. So we consider that a inhibitory neurotransmitter, and glutamate is an excitatory. So when you drink alcohol, GABA is one place that alcohol goes to. So what do you think is going to happen if you drink? You're going to get more GABA. So your body's going to feel that relaxed, warm feeling, and your glutamate's going to go down. And that's the excitatory one, right? That's what one of the several reasons why we tend to get shaky, or even if you have like one night of partying, you might even feel like hungover is like a minor form of being in withdrawal. So just imagine that like times 10. I cannot even imagine, but I've seen it and it's just awful. So what Cambrel is thought to do is if we can equalize those, the quicker that we're able to equalize the basically neurochemistry in our brain, I'm going to keep it very broad, the quicker it heals. And as we're healing, we never cure addiction. It's like most cancers and other diseases and disorders. We're not curing it, but the quicker that we're able to, get our brain working in a more efficient way, then we're able to make better decisions. The downfall of this medication is that you have to take it 3 times a day because your liver metabolizes so much of it. You must take 666 milligrams 3 times a day in order for you to get the therapeutic effect that is FDA approved. And I think the reason they do that, just fun fact, is, and I don't know, I do know, I think. So you actually have to take 2 pills 3 times a day because the pills come in 333 milligrams. And if you do the math, 333 plus 333 is 666. So I think marketing wise, they thought, probably not a good idea. So somebody, I mean, just, I don't want to say normal because we don't do that, right? But just some people are not really good with med compliance. I mean, not because they're not trying to be like bad patients or whatnot, just they're just not good at keeping on track with things, as taking certain things at 3 times a day. I mean, that can be pretty difficult, especially newly sober and trying to remember and just do everything you're supposed to be doing and having all the chaos and potential drama in your life. Who knows? So that's one thing as a clinician and a nurse that we can do for our patients is we can do like what I do beforehand. I do the admission and intake and assessment and kind of be able to give the physician a rundown. If they're really bad at med compliance, this probably isn't the best med for them, especially if they don't have somebody maybe at home to help. Because again, if you're not taking it 3 times a day, it's not doing what it's supposed to be doing. You're just wasting, it's doing nothing. Also, as a fun side note, if you have a really, really bad liver, Cambrel works more with the kidneys. So that's one to go to. The whole reason I'm mentioning that is because this just opens up the big picture of understanding and knowing things. Because when we go to the next medication, that one's a little bit harder on the liver. I know that sounds funny. It's like, well, why would it be hard on the liver if it's for alcohol? Obviously, alcohol is not good on the liver. Yes, true. Although naltrexone and Vivitrol have an extremely high efficacy, but it's good to understand medications, and gabapentin as well as more kidney, because then you can understand the patient, hone things down, know the resources, know what might work best for them, and try to do the best for them up front. And if something doesn't work, then you ask yourself, what else can I do? What else can we do? And also, it doesn't you don't need to take a medication. I never pressure my patients to take a medication. I do a medication education class about anticraving meds. We do a fun, what's that thing called? Not word search, but the other one, crossword. Makes it a little bit fun and entertaining. And then we have one more that covers a little bit of medications, but they're more mental health meds. Because I think that, knowledge is important, and who knows what we're just going to work for one person may not work for the other. So give them all the information possible, right? So that's Camprol and gabapentin. We talked about benzos. We talked about phenobarbital. We talked about the CWAS scale, as well as I did post it. But again, I'm going to go back up to naltrexone in just a second. The CWAS scale is a scale used basically. So it's a clinical institute withdrawal assessment. It's for alcohol specifically, and it's basically a doctor will write, or whoever's in charge, the clinician will write in order to how often to do it. And you can see it if you look it up on your canvas of what it entails and what you're looking for. It's sweating and different tremors, potential withdrawal symptoms, so that you're able to get a good idea of what's going on. And then it'll say, okay, if they're between this number and this number, you give them this much of either Ativan, Librium, whatever medication that they prescribed. And again, please, this is where the assessment part comes in. If it's not working and the patient looks bad, what are we going to do? We're going to call that physician, MP, whatever. We're going to call them and say, I'm following the CWAS protocol. Patient's blood pressure is still, 160 over 95. Pulse is racing at 122. They're diaphoretic, but everything else is good. So it's causing the score to go low. I believe that we, again, SBAR, right? I believe it would be a good idea to increase the medication for the next 36 hours and see how they're doing, or whatever it may be. So that we can definitely do that. And I've done it several times. Now, naltrexone and Vivitrol can be used both. So I'm going to double dip here. It can be used for opiates and alcohol. And when I say that, most people look at me like, what? Huh? What? And that's because how I mentioned earlier. So alcohol, it goes to about 5 different receptors in your brain when you drink, GABA being one of them, and opiates being another. So because it goes to your opiate receptor, I personally believe, because that's the only one that goes to the reward pathway. So if it didn't go to the opiate receptor, I don't think it would be addictive. Think about it. So we have what's called endorphins, right, in our body. And if we have endorphins, and that is caused from sex, exercise, food, why do you think all those things are possibly addictive? Because endorphins go to your opiate receptor. That's your natural opiate in your own body that you make. So if when you drink alcohol, one thing that happens is endorphins are released. What do endorphins attach to? They attach to the opiate receptor. If something attaches to the opiate receptor, we know that opiates have the potential to be addictive. They give you hydrocodone, Percocet, oxy. We know that those are potentially habit-forming, and we know those go to the opiate receptor, right? And we know if something goes to the opiate receptor, that it ignites from the VTA in the reward pathway dopamine, which equals the euphoria, which equals the reward, which will equal the potential not potential, but it does give you a reinforcement of the behavior. Not everybody gets addicted, though, of course, we know that. So what naltrexone does is naltrexone is the oral form of it. It only works 24 hours though. So you can plan for that day. Oh, I'm not going to take it tomorrow and I'm going to get drunk, right? If you drink while you're on naltrexone, you do not get sick. However, you do not get drunk. It blocks the opiate receptor, remember? So it's not going to the VTA and the dopamine. However, you cannot, if you drive, you could get a DUI. You will blow a positive number on a breathalyzer. If you stumble around, I mean, you actually get to see yourself drunk, is from what I heard. I mean, we're not encouraging that, of course, but I've heard some pretty interesting stories about how I've had a patient tell me, God, I'm an idiot when I'm drinking. I thought I was cool and fun and this and that. And this is not me being derogatory against the patient. I'm just repeating what the patient had said in group. And you actually see yourself drunk, but you see it, you don't feel it. You feel a tiny bit because it's still hitting GABA, and GABA causes relaxation, but you're not getting what you want. That leads to, well, are they going to overdose? With alcohol, usually people just pass out and they go to sleep. I've never had one patient. I've never seen the research showing that this will, excuse me. I've never seen a patient have an overdose from naltrexone. So it does have one of three properties that I think are very useful. Again, naltrexone is the oral medication, a tablet. It lasts for 24 hours. Vivitrol is the same thing as naltrexone. However, it's the injectable form that lasts for 28 days. And of course, 28 days, then we know it's in your body. And, we all know why having the injection, because we can't plan. We can plan for the bad days, this, that, the other. So same thing, same active ingredient. It's just it's an injection. It goes in the gluteal area. It's a very viscous medication. So the injection, not everybody is like yay about getting it. So, but very effective. And you're less likely to have side effects from the injection. Fun fact, because naltrexone, again, your liver breaks down a lot of the medication. So really you only need like 13 milligrams in your body, but you take 50 milligrams for the therapeutic range, therapeutic level of the medication for naltrexone that's oral, because if you do the math, I think it's 380 that you're getting per 28 days if you do the division. So really you only need, it's 11 or 13. I think it's 13.8 or something milligrams of the medication, but because if you take it orally, your liver breaks so much of it down, you're taking more. So you're more likely to have side effects as well if you take the oral versus the injection. Just again, fun side note. Now, three things. So you take naltrexone, it helps with cravings because it's covering a receptor. So usually when I ask my patients, how do you find this helping you? The most common answer I get is either, I don't really know. I don't know if I'm feeling it. I don't know if it's helping or if it is or not. But more often I get the answer of, I've noticed that I'll be at work or doing whatever it is that they're doing. And normally they might think about alcohol like 30 times between breakfast and like lunch. And they've noticed they maybe only thought of it like 5 times. So, I mean, that's good, because that's actually can cause more cravings, because your neurons are like a muscle. So every time you think of it, you're building the muscle because you're having a craving. So that leads to the third reason, which I'll get to. And it's not actually in the research, but this is my opinion. So you're helping with your cravings because you're covering the opiate receptor. Plus, if you do drink, you don't get drunk. So you're not reinforcing it. And hopefully the next day you wake up and you normally will have a worse hangover. We'll just jump right back on that wagon and say, you know what, I made a mistake. I'm starting over. And then thirdly, if you're thinking about something less, and it's like a tree ring, like when you cut down a tree and you have those rings, if you're not building that muscle in that neuron, like a muscle, and you're thinking about it less, don't you think that you're going to have less thought? Okay, you're having less thoughts, therefore you're making that neuron shrink. Therefore, your brain will heal faster. That was research I did on my own, kind of on the side, and that's my personal opinion. The doctor I work with, some of you know him, at Mission. I can already see you probably shaking your head like, yeah. We disagree, but that's okay. And I always say when it's my opinion versus evidence-based. I've not found anything, although I have heard a doctor talk about it. So, there you go. That's what's important to know about that. So alcohol, and for opiates, of course, we're covering the opiate receptor. So now naltrexone and Vivitrol have a higher affinity for the receptor of the opiate receptor. So if you were to use, you're just using on top of it. So it can potentially cause an overdose. I personally have never seen one, but you really need to, same thing. I would have my patient sign something saying, I understand this could happen. Now for opiates, what I will say again, and I don't think I mentioned this in the beginning. Oh, I did, about the cocaine stimulants. They do not have like an FDA approved, but again, like let's say a patient's, oh my God, I'm so anxious. And it's the very beginning, I would give them something that's fine, help them out. If they're having trouble sleeping, all of that. We can do other things than just anti-craving meds to help with feelings of withdrawal. So with opiates, we have the cow scale, same thing. And I use the cow scale for many, many reasons. We can use it to give medication, how much medication to give. I personally use it more so before I start these two meds, and I will explain that. In quick, clonidine, old school. It's a blood pressure medication. We usually give it at 0.1 milligram, Q2, Q3 times a day, depending on the physician. It kind of, I mean, for some people, it's not my favorite, but it can help for people who don't want to go on methadone or Suboxone, because those are both considered harm reduction, which means that it's reducing harm, but it still does activate the reward system a little bit. All the other medications, by the way, other than the ones that I told you, like obviously benzos do and phenobarbital, because they're Schedule 4. The other ones do not. Antabuse, Camprol, gabapentin, Vivitrol, and naltrexone are all considered MAT, which is medication assisted treatment. I mean, they kind of all are, but they do not excite the reward pathway. So clonidine is a blood pressure medication, and it's given to people who are in withdrawal from opiates if they don't want to use another medication, or we just give it to them because they don't know, and it helps some people. I don't think it's a bad medication. I just personally have not gotten a lot of like great results from it. Personally, if I were the physician, I would give somebody who's withdrawing off of opiates benzos. That's just my personal opinion, because it helps them relax, they sleep. It helps with the withdrawal, or Suboxone. Those would be my two. But again, that's me. Other physicians might be, I mean, we're getting a little more, I think, creative instead of this whole, we're definitely learning a lot more. And from what I've seen. Yeah. So for withdrawal, another thing that we can use, personally, I don't care what anyone says, methadone, and this is my opinion, but methadone is, you don't want to use that for withdrawal, because by the time you get the right dose, it's like, then you're withdrawing from methadone. So unless you plan on being on methadone, in my opinion, and several physicians' opinion, there's really no reason to go on methadone unless you plan on being on it for a few years. We'll talk about that one next, I guess. So methadone is a pure opiate. It's a harm reduction. There are methadone clinics. We've talked a little bit about this, I believe. I would say you are replacing one thing for another. It is for opiates. Just a reminder, heroin is an opiate. It is usually given for those who are using heroin, whether you're shooting it up, snorting it, smoking, whatever. But it can also be used for, oral opiates such as Oxy or whatnot. And the point of it is so that we find that perfect dose where you're not feeling so high. So you are obviously igniting the reward pathway, and they use methadone. It's a great opiate. I'm not saying I'm not saying any of these medications are bad, even though they're habit forming. It's how they're used. So just like with anyone or anything, things can be abused in the system, but I'm going to talk about it just from a pure, black and white situation here. So our goal with methadone, and as most of you know, I worked at a clinic for a little over 2 years, loved it. Just helping I just love the patients. It was quite a ride. And how this works is you must be in somewhat of withdrawal for both methadone and Suboxone, keeping that in mind. And I'll tell you why. And this is why I utilize the Cow scale. If someone's not in mild withdrawal, which it says straight on the Cow scale, if you look at it, what mild withdrawal is, I can't remember all the numbers. I think it's like 5 to 12 or something like that. That might be CWA. I haven't used it in so long. I personally don't like the scales. I just do it to CYA. And for cows, not for CWA. But for the Cow scale, because I don't want to induce withdrawal. So I make sure and show, hey, thus far, knock on wood, in 14 years, I've never induced withdrawal. So what I mean by that is because methadone and Suboxone both have a higher affinity for the receptor. So it is on the receptor. So if I were to give you, let's say you did heroin, and heroin's actually pretty short acting. I know in about 6 hours, I can give you methadone or Suboxone. I know that. But I'm still going to do the Cow scale so that I have the number that says you are in moderate withdrawal. Once I have that, I feel confident because I have it in written that I did the assessment, the patient, it's objective and subjective if you look at it. So, if they did go into withdrawal, it shows that I did what I was supposed to do. And for whatever reason, their body just didn't respond to it well. And that's why, and of course, we don't want that to happen. So we want to be as the best we can be and make sure that doesn't happen. So methadone usually takes, honestly, probably about And the reason it does happen is because let's say you're taking a medication, let's say you're on heroin and you come in and you lie and you say, I haven't taken heroin in a day, man. Oh my God. I'm like so distressed. But you took heroin an hour ago. What's going to happen is you take methadone or Suboxone, it's going to go in there, pull the heroin off the receptor, and you're going to go into full-blown withdrawal. And it is awful, and there's nothing that can be done. The methadone and Suboxone won't stick to it. Even though it has a higher affinity, it doesn't stick to it, just pulls it off, and they all go away into your bloodstream, and then they do nothing. So you don't want that. So that's why we always say, please be honest. You're going to be suffering a little bit, but you're going to feel much better. So usually methadone takes about a month honestly to get regulated and to get the right dose. The hope is that you're on the right dose. You're not on a dose that's making you nod off, not like falling asleep, not safe to drive. You're on that perfect dose where you're able to function, work. Heroin, again, you have to, and most of the patients that are on methadone do use heroin, but again, they can be on another opiate. And you have to shoot up heroin or use heroin quite a bit because of the short half-life. So it's really hard to hold down a job, take care of your kids. So that's, I think, enough about methadone. Suboxone, I mean, in my personal opinion, I mean, that's kind of the dream. I mean, if we could give everybody Suboxone, but it's expensive. Methadone is usually covered by Medi-Cal, and I mean, you can go to the clinics, and you don't want to be walking around on the street with methadone. So usually in the methadone clinic, you get one dose unless you have take homes because you have a place to live and you have a lockbox, and there's all these things. And by the way, with a methadone clinic, you have to see you're drug tested a certain amount of times a month. It's not just some free for all. I mean, they have you have to go to counseling. If you don't, then they deny your methadone. I mean, there's things put in place to try their very best. It's not just some like big fun, like, hey, come get some free drugs, right? But as I have said it in class, we're all entitled to our opinion. Absolutely. I'm just giving, the more I can give you, I think the more you can form an opinion if you do not know what it is. So lastly is Suboxone. So Suboxone, you might have heard the term Subutex. I'm not going to talk about Subutex because it's so similar, and I don't want to overwhelm you because I already feel like, and I'm doing this all just off the cuff. I'm just sitting here looking at my chandelier and talking. So Suboxone, so methadone, just food for thought, is a Schedule 2, which means it can be extremely addictive. If you're going to prescribe it for the purposes of methadone treatment for drug abuse, you must have a certain certification. If you're prescribing it for pain, you do not need one. Suboxone, you must, if you prescribe it, have a special ID when you call in the prescription. Now you can call it in. Before you couldn't, because it's now Schedule 3. So Suboxone can be used for one of three things: either withdrawal coming off of an opiate, maintenance, just to help with the cravings, buy time, help your brain heal, or pain management. Suboxone has a ceiling effect, meaning that the highest dose we go is 32 milligrams, because if you go higher than that, it doesn't do anything. Methadone, unfortunately, I would see about a death every 4 months at the methadone clinic. Suboxone, that's why they do that, because it's I mean, it really is. It is safer in the fact of the medication, but again, if you're living on the street or you don't want to get like robbed and this and that, and there's a reason why you'd go from methadone or Suboxone. It does take a long time to get off Suboxone, by the way. So a lot of people that are on it may be on it forever. Not everybody though. Now Suboxone, basically, again, opiate. It's for opiates. Suboxone it's usually now, I think, they still have the tablets, I believe. I don't get to work with it as much now that I'm not working in residential. I'm more in the hospital, and we don't really use it as much as I think we should, because all the people that come in are usually there for alcohol, and I'm like, come on, can we get someone else? No offense. I'm just like, it's kind of cool to have like a group of like, oh, 2 people are here for meth, one's here for opiates, 3 are for alcohol, one's for marijuana. It just kind of, makes it a little bit more interesting, in my opinion. But So Suboxone is what I call, it kind of plays with the opiate receptor. So you're getting a tiny bit of euphoria, and this is what Ruth Poche talks about. Hopefully you watch this part of the video, is that those that are taking Suboxone, they're almost too quiet because you don't know that they're on it. They're not acting high. It helps with cravings, the efficacy, just like naltrexone up here and Vivitrol. And that's why insurance is starting to pay for it. So this shot used to be $1,800 out of pocket. It was so hard to get it covered. I mean, I won't even get into it because it infuriates me. Suboxone, same thing, because you can go, I mean, I would say the average person took about 8 milligrams in the morning, 8 milligrams in the evening. And they both have very long half-lives, these two. That's why when people ask, well, why don't you just give Vicodin? Well, because methadone has a long half-life, you go to the methadone clinic every 24 hours, right? So same with Suboxone, has a long half-life, but also you have to be in moderate withdrawal. Same thing, has a high affinity for the receptor, the opiate receptor. So I wait till you're moderate withdrawal, you feel horrible, then I give it to you. And usually the first dose, you feel much better. Second dose, much better. By about the third dose, you're like, wow, this is amazing. And usually people, like I said, take it maybe in the beginning 3 times, but usually it's about twice a day. Sometimes it's once a day. It just depends on how they're doing, who it is, who the physician is, what their history is, what the past is, what they're taking, how many milligrams. That's not the point. The bigger point is, what is it for? So if you can recognize what these medications are for, I think that's the most important part. Is it for withdrawal? Is it for anti-craving? You don't have to remember all of this. I probably said 50% of things that you don't need to remember and won't, and probably about 35% of things I want you to remember, which will be on the study guide. So I hope I gave enough information. Just the last thing I want to say, Suboxone must go under the tongue. That is the only way it's bioavailable to your body. It must go under your tongue, whether it's a tablet or the film, because the vascular system, those vessels under your tongue, take it in. If you swallow it, your liver doesn't know what to do with it, and you completely waste it. So that just, like, again, I'm not going to test you on that, but just to bring everything together. So, and as I said down here, many other medications can be used to assist one that is going through detox and or recovery, such as medications for symptoms. A few examples: insomnia, depression, or any other mental health diagnoses, especially those that come up once you stop using your drug. Because a lot of things can come up, as well as lifestyle, meditation, exercise, food choices, and environment. It's a whole thing, not just here's a pill, you're going to be better. Not everyone needs treatment. Most people, it's much more beneficial, but treatment, all of these things, it's a holistic process. So I hope this was helpful. I'm going to post it, and I said everything that was important. Please do not stress about, like, oh my God, I didn't get half of that. Again, it's going to be on the study guide. And I didn't make this too long, so you can always go back. And if you have questions, please ask. And I hope that this was helpful, and I will see you all very soon. Have a great day.